And I have to say, I'm inspired to be here today, just because just hearing some of the stories and some of the stuff that's going on, it's just unbelievable. So I'm really happy to be here. I was telling someone out there, it kind of fills my tank when I hear some of the stories as a doctor. It can be very busy. And I was just thinking, I had a busy clinic yesterday, and how tiring it was, and then to come here and to hear this, it just kind of, like, I'm ready to go. I'm ready to see a whole nother week's worth of patients, which is amazing. And then I also want to mention that when I was preparing this talk, my daughter, 13-year-old daughter, came in. She started looking at what I was doing, and she paid about two seconds of what I was doing. She's the PowerPoint, what's that? And then she walked off. But when I go home today and tell her I was on YouTube, streamed on YouTube, that's it. I think I'm gonna, and trust me, I'm gonna use that. So I'm gonna use that. So let's get started. Some disclosures. I am a paid consultant for Lenient and Horizon, but I'll bring that up at the end because I want to mention that the funds that I use for that I've been putting towards a local event that we've been having, thanks to the Moores and some of the other families here that have kind of inspired us to do some local education, which has been tremendous. So we'll review what is cystinosis. And this is going to be a very basic talk, so some of you guys know more about this than I do. Who's affected? Why does cystinosis occur? And you'll even see, you've learned some stuff out here about why we're not so sure why cystinosis affects other organs more than others, and how it happens. And then we'll talk a little bit about diagnosis and cystinosis, how to treat cystinosis, and my talk will then dovetail into the upcoming talks. So what is cystinosis? Why are we here? It's a rare genetic disease. And when people hear genetic disease, they think, oh my God, what does that mean? There's no cure. But you have to recognize that it's a treatable disease. And that when you look at genetic diseases, 50% of them are treatable. It's a disease of the lysosome. And then I'm going to show you in very basic terms, and I will use the image of a trash fire, believe it or not, in describing what a lysosome is. But that's the disease process itself. And it's basically due to a transporter that normally takes cysteine out of a lysosome. And without that, we see cysteine accumulating and causing crystals to form in cells throughout the body. So who's affected by cystinosis? Really, it's a very rare disease. We think there's maybe 500 or 600 patients affected in the country. And what we have to recognize is that the vast majority of patients, and there's some exceptions to this, are affected very early on in life. And one of the first manifestations is kidney and eye disease. And then this idea of approximate life expectancy, this is something that's changed as time has gone on. So I don't know if we can answer that question now. And that's a good question not to be able to answer. To say, hey, you're born with cystinosis. Doc, how long am I going to live? What's my life expectancy? I can honestly tell them, I don't know. And that is a powerful thing to be able to tell a family or a patient, as opposed to before renal transplantation, well, we're going to be stuck with renal failure, or before cysteine depleting therapy. So I want you to keep that in mind as we move ahead. And then I just also want to remind you that any disease you talk about, when someone asks you, well, what's the prognosis? That's all based on the past. It's not even based on the treatments that are current, and doesn't even take into account the treatments that are going to be available. So that's also a very important thing to recognize. So the genetics, oh my God, we're going to be talking about genetics, right before lunch. Everybody's going to nod off, but I'll try to make it as entertaining as possible here. Essentially, this is a genetic disease. That means you're born with it. And you've heard already several times over that it's a disease of a transporter. So it's a disease that the gene that describes this transporter is defective in somehow, and you're not able to make enough or the correct version of this transporter. There's a lot of mutations out there. The most common is this large deletion, and this comes back to Clint's walk, the 57-mile walk, that 57.2 kilobyte deletion. That's the origin of it, the most common one we see. Here's this idea of autosomal recessive inheritance pattern. So you have to go back to learning about P pods in Mendelian genetics. But essentially, a lot of times says, well, my child has a genetic disease. How did that happen? Well, this is a disease where we're both given 2 books of genes, of genetic code, and the mother and the father have one good book and one book with like a paragraph missing, for example, a critical paragraph. And just by chance, 1 out of 4 of their children will inherit both sort of defective copies of the book and come down with the disease. Another half will be carriers, and then a quarter will have inherited 2 normal books. Does that make sense? I think that's very important for understanding. And it's also very important, sometimes we forget about the siblings out there, you know, when they hear about a disease. Well, what does it mean that my brother or sister has a disease? I think that this is a very, you know, a way of trying to explain to them that, hey, this is a disease that you're born with. This is why you might be different from your brother or sister. And this might be a disease that you might have to learn about, not because you're going to have the disease, but you're a carrier of the disease. So the genetics, what happens here, and then we're going to go through the lysosome here, a lot of fun, but I'm going to try to use an analogy in a second that borrowed from Dr. Grimm. But essentially what happens is you have defective or absent cystinosis. And so in a normal lysosome, you can see here, if I can read in the purple, this is an amino acid lysine that goes through a transporter. You say, why are you mentioning lysine? I'll tell you in a second. And then cysteine here is in the yellow. It normally moves through its own transporter. However, if you're missing this cysteine transporter, you can see the lysine still gets out, but the cysteine sits there and accumulates in cells. And when it accumulates, it basically destroys the lysozyme. So, and here we are. This is Dr. Grimm's, where is he out there, his recycling plant. And actually, this is the 3 of us doing our day job here at the recycling plant. I won't tell you who's who, but it's... but so if there's a you have this recycling plant, and you have this metal guy, metal guy, wood guy, and paper guy here. We'll just say I'm the paper guy since there's a roll of toilet paper there. And what ends up happening is that's what's happening in these recycling plants. Your body is very, takes advantage of the fact that it can recycle proteins and recycle. So what happens if the paper guy says, I'm going to go out for a cigarette break, leaves the building, and never comes back, right? Well, things go along okay for a little while because the metal guy is still doing his job, the wood guy is still doing his job. But what eventually happens is all that paper builds up, and the paper here is like the cysteine building up in the recycling plant, and boom, what happens? A recycling plant fire. Who would thought you'd see a slide of a trash fire, basically, on a talk of cystinosis? But this is what happens here. So if you're going to remember what happens in that lysosome, this is what happens. That you're basically unable, all that paper starts building up in the lysozyme and causes destruction of the lysozyme. And what's tough about this disease is the lysosome is present in every cell out there. So you wonder about, well, why does it affect muscle, heart, not heart, but muscle, kidneys, eyes? Why is the whole body affected? It's because the lysosome's affected. Lysosomes in every organ of the body. Any questions about that? Or I guess we'll save the questions to the end. But so where does cystinosis manifest? And this is also another kind of tough question to answer in the sense that we're not always so sure of the why. Why is the kidney affected before necessarily the thyroid or your endocrine organs like the pancreas? We don't know 100%. And this is some of the questions that Dr. Sarwal is trying to answer. And with the hope of answering those questions, we can go back and treat the disease. But we definitely see this kind of natural history of the disease. And you see the various organs that are affected. And I won't go into tremendous amount of detail of the various organs that are affected, but I want to remind you of 2 things. One is that there's a treatment out there, and that's called cysteine depleting therapy, and I'll review that in the next couple slides. And that has altered the natural history of the disease, so that when I was a medical student, I would have seen a different slide. Or if I was a medical student before transplant, I would have seen a different slide. So who knows what we're going to end up seeing in the future? So I always leave an arrow pointing forward as a question mark. So those are the two things I want to mention when we talk about where does the disease manifest. This also gives you an idea of sort of when we look at large groups of patients, some of the age-related clinical characteristics of untreated nephropathic cystinosis. So unfortunately, the treatment isn't 100%, but in a lot of the organs, we can prevent the progression of the disease for the most part. I was just talking with Dr. Grimm about what organ systems can we actually reverse disease in, and what organ systems we can kind of slow the progression. Muscle is one of those things that we see that we can slow the progression of the disease if you maintain on cysteine depleting therapy. For whatever reason, the kidneys, although we're able to, and you'll see the next slide, you're able to kind of prolong kidney survival, we're not there yet. Everybody still ends up needing a kidney transplant for the most part. So and this shows you why is a nephrologist talking to you here. Well, this idea, one of the first organs affected is this renal Fanconi syndrome. And this basically shows you, we're really diving down deep, is this one part of the tubule is affected the most. And you can see a normal-looking glomerulus filter unit and the tubule, and then cystinosis later. And this failure of the proximal tubule leads to this kind of wasting of necessary minerals and chemicals that you need to grow and thrive. And I'll talk a little bit more about that in the treatment as well. Unfortunately, when you lose those necessary chemicals, minerals, you also lose water. And so one of the things we can often see is dehydration and this idea of failure to thrive. And then finally, because you do not absorb enough of your calcium, and in particular phosphorus, and you waste those in your urine, you can develop a childhood disease of bones called rickets, where you present with sort of bent or bent bones here. And this disease, this renal Fanconi syndrome, you'll see dehydration, failure to thrive, rickets. Those are three other diagnoses that are general diagnoses that you might be diagnosed with before someone comes to you and says, this is the disease you have. And part of the challenge of having a rare disease is the recognition that it often takes, even in the Northeast corridor where we are, where we have more doctors than you can, throw something at, is that often, even in this area, it can be 6 to 8 months before someone finally makes the diagnosis. So this is the eye that can be affected. This is one of the organs that you basically, with cysteine depleting therapy, you can essentially, in the cornea at least, reverse disease here. And this is a very powerful thing that when you show someone their eye full of crystals and then they start using the eye drops, how quickly and how successful you're able to remove those excessive crystals. What about some of the adolescent clinical characteristics? This idea of these proximal muscles, we see proximal muscle wasting and some hand atrophy. Sometimes we see cerebral calcifications and brain atrophy. And we'll see if we do some very specific neurocognitive testing, we can see some deficits. I'll once again say that these deficits can be slowed down with treatment. And that idea, you always have to, whenever I say something about the natural history of the disease, you have to say, well, what about with treatment? More of some of the adult clinical characteristics. I mentioned this kind of proximal weakness over here. And then the actual cornea is fairly easy to treat, but the retina, which acts as is more of a just sort of part of the body, can be much more difficult to treat. And then unfortunately with muscle weakness you can develop swallowing difficulties. Making the diagnosis, I already mentioned that when I showed you that one slide. If we just considered the kidney manifestations, right, you could be diagnosed with dehydration, this Fanconi syndrome, or rickets, and you really have to go past that. And the idea is, I used to say to medical students and residents, if you don't think of the diagnosis, you'll never make it. And this is especially true for rare diseases, especially true for rare disease. And a patient came back to me and says, Dr. Zaritsky, I want you to stop saying that. This is what I want you to say, and I haven't edited the slide. He says, I want you to think of it this way. You might not have ever seen the disease, but the disease has seen you, right? And I think with that thought in mind, especially for some of the younger doctors here in the audience, or think about that. Think about that idea that you might not have seen the disease, but the disease has seen you. And that kind of puts more of the onus on the doctor and the treating physician. And unfortunately, a lot of times patients in the audience, you're the ones who are going to have to go out there and educate those doctors, about the disease. It's that rare. Okay. These are some of the other diagnoses that children might receive. What about making the diagnosis? One of the cornerstones is actually measuring cysteine, that accumulation of cysteine in lysosomes. And thanks to, we're sort of standing on the shoulders of giants, this idea of testing, how do we get a level of what the cysteine is? We now have two assays to look at the cysteine in white blood cells that gives us an idea of the overall burden of cysteine in the body. And if we look at patients, who have 2 normal copies of the book, or people with 2 normal copies of the book, we get a level like this. And when we start looking at patients who are carriers, or people who are carriers, they have another level. And then we see this idea that patients who have 2 bad copies of the gene, they have levels that are really an order of magnitude higher. So when someone suspects the diagnosis, if they're able to get this test, this really confirms this. And this then becomes a way of us helping to monitor therapy through time, and how well the cysteine depleting therapy is available. I won't spend too much time on the different two types of tests. I have to say that the availability, the testing methods, and the collection sample has gotten a lot easier over the last years, and the availability of testing has also become a lot easier. So that used to be something that kind of got in the way of you going out there and getting treatment. Who's going to follow the levels? That has got information. But occasionally, you're able to make the diagnosis of a very rare disease just by checking the genetic diagnosis. So right now, it's really a clinical diagnosis. The child presents with this renal wasting syndrome, and then we check a cysteine level, or they have rickets. But I think that genetics is gonna push that forefront. And you can imagine a day and age 50 years from now where a lot of these rare diseases are made the diagnosis is made at birth or before, where you have a genetic panel laid out there. All right. Moving forward, what about treatment? So this is the one time I get to make my own and show my own slides, is when I talk about this Fanconi syndrome. And Fanconi syndrome, and there's several other renal diseases that also cause a Fanconi's-like syndrome. It's essentially like I give you a bucket, and I said, hey, go build this structure. Here's your concrete bucket. Here's your phosphorus bucket. And then you fill up your phosphorus, you fill up your calcium, and your buckets have holes in them. So you get to the job site, and I go, well, what are you doing? How are we going to make cement? You don't have any substrate to make the cement. That's the idea here. That's the idea, that the kidney just acts like a sieve. All this important stuff is being leaked through. And so the treatment that we use basically is just by pouring more water in the bucket, right? And so that doesn't sound like a very, we'd rather plug the hole in the bucket and fix the kidney. And for some other diseases of the proximal tubule, we've been able to do that. In this particular disease, we're not, so that patients end up on a huge number of supplements. And this idea of what, as a teenager, what kind of affects your ability to treat the disease is just this. Sometimes I mess it up, and luckily I have families who are double-checking me. So, but the patient is at the end of the day has to take it. There's some other therapies that are also supportive, this idea that we support the endocrine organs, particularly the thyroid, and then also sometimes we use growth hormone. What about cysteine depleting therapy? This is another chance that I get to stand on the shoulders of giants, that the idea that someone was smart enough to come up with this therapy. It's actually quite amazing. This is this idea, this untreated cystinotic lysosome here, where you have this accumulation of cysteine. Well, someone very smart thought, how about if I modify this cysteine so that it can go out through the lysosome transporter? And that's exactly